So our next speaker is Dr. Khawar Hussain, and he's a consultant adult and pediatric dermatologist and an honorary senior clinical lecturer at Imperial College. He has over 60 peer-reviewed publications and is involved in clinical trials. And Khawar, you'll be talking to us about scalps, which I think are an incredibly difficult area for patients. So I think this will be useful for everybody. So thank you so much.
Thank you, Emma, for the very kind introduction. Thank you, Hiba and Leisha, for the invitation to speak. I'm acutely aware that I have various different clinicians in the room. If there's anything that someone doesn't understand, please just feel free to raise your hand. More than happy to stop and go through things. So these are my declarations. So these are the objectives that I would like to go through today. So I'd like to appreciate the importance of examining the scalp, which often gets forgotten about, understand the common causes of a scaly scalp, to highlight the importance of specific types of investigations, which I will hopefully go through case examples, and then to think about treatment options. As my colleague, Professor Cork, also said, try not to take any photos. And one of the things, if anyone has any children, will know about this is Chase. I've just specifically highlighted a few different points that I think are very useful clinical gems for us to be aware of. So dermatology is a study of the skin, hair, and nails. And the last two areas often get forgotten about. And often in our practice, because we're so busy, sometimes we often forget to look at the scalp and often forget to examine areas which are of vital importance and can give clues to the underlying etiology of various different conditions. And hopefully over the next few slides, I can try and highlight that as well. So we're going to start off with section 1, and you'll see there's a theme for each section. So you have a 4-year-old boy in your clinic. He's had this painful area on his scalp for the last 4 to 6 months. It's not been getting better. Parents have shaved the scalp to try and help with the symptoms, but nothing's been helping. They've tried a few topical treatments and nothing's cleared. Can anyone shout out what they think is going on? Yeah, tinea capitis, but this is something a little bit even more than that. This is something called a carrion. So carrion is a painful, inflammatory, boggy mass that's a delayed response to a fungal infection, and you get granulomatous inflammation. Often you can have vesicles, pustules, and you can have scaling. And especially in our skin of color patients, you may not always see that inflammation, and you may not always see that erythema. So you have to have that index of suspicion there. Fungal scrapings and sending hair samples is of vital importance, but often that can take a long time to come back. And I know there are now PCR methods which are a lot quicker, but that is not available everywhere. So if you have that index of suspicion, you must treat early, because this inflammatory condition does cause scarring hair loss. So it is important to treat. And often in my practice, I have seen patients who have had topical shampoos. They may have noticed a mild improvement, but topical treatments do not clear tinea capitis. You may notice a mild improvement, but you must use an oral agent. And most of the time we use terbinafine, which is weight adjusted for in pediatrics, which is the most prevalent, which is where the condition is most prevalent. And you have to use it for at least 4 weeks. And often, sometimes you do have to increase the length of use depending on how severe that inflammation is. And there can be secondary bacterial infection or impetiginization where you have to add in antibiotics as well. By then, you should have got your fungal scraping results back. And if there are any problems, you feel that the patient's not responding, you can always discuss with microbiology colleagues regarding sensitivities. And that's why I've highlighted in red in terms of topical shampoos. There is a role for topical shampoos, whether that's, and I'm going to touch on that at the end of the presentation. And there is a role after treatment to try and reduce the spore count. And I've just highlighted 2 of the most common species that we tend to find, but trichophyton tonsurans tends to be the most common cause. So I've highlighted three different pictures on this slide to explain that you don't always get that inflammatory cause. You can get a non-inflammatory variant of tinea capitis, and you can see that with the grey patch on the right-hand side, and then you can get broken hairs in the middle. So always think about that as well when you see patients. And then a very rare variant where you get very thick scales occurring, and this is called a favus. Thankfully, in the UK, it is not common. So sticking on the infectious theme, other causes of scaling that you can get in the scalp is impetigo, and you often get that sort of scaling on the scalp in pediatric and adolescent patients, and often you do need to treat with oral antibiotics if it's not responding. And often you have to look in the scalp and you have to take some swabs to try and confirm. But most of the time these patients will respond to either topical treatments, shampoos with antimicrobial activity, but important to be aware of because you can get spread elsewhere. And highlighting this even further, you can also get vesicles and crusting, which if there is a background defect, as my colleague spoke about, like eczema, you can also get eczema hepaticum as well. So very important to look at the scalp and make sure you take your viral swab, treat with IV antivirals, as there is a risk of spread as well. Other infectious areas to think about on the scalp, think about lice as well when you're examining. A lot more common than you think, especially in certain populations, and that can be a predisposition for other things as well, such as not everything that itches is eczema, and often the scalp often gets forgotten about. What condition am I hinting at here? Scabies, perfect. So very, very pertinent in this in times now, especially over the last 12 to 18 months, there's been an increase in scabies cases, and often if you look back in the literature, scabies was thought not to affect the face and scalp at one point, but that's actually not true. So often you have to make sure that treatment, whatever you use, if it's a topical agent, must cover the face and the scalp. And especially in different populations, such as in neonates and in those who are immunocompromised and the elderly, you can get scalp involvement as well. So important to be aware of. And think about other infestations at the same time. So if we move on to section 2, so now we're thinking a little bit more about inflammatory causes. So very, very common things that you might see in your clinic. You might see very non-specific erythema, you might see some scaling, but then you might start to see a bit more scaling and thicker areas that are starting to extend over the hairline onto the face or the back of the neck or on the hair. So this is scalp eczema and scalp psoriasis, so very common things that you will probably come across in your GP consultation clinics and further afield in secondary care. It's not always easy and clear-cut that eczema is more itchy than psoriasis, but generally it tends to be psoriasis can be itchy on the scalp as well, so just important to be aware of. Eczema generally tends to have very, very non-specific borders, but psoriasis tends to be a lot thicker in nature, and you do get things, especially you get carbonization, so if you have any trauma, psoriasis can occur in those areas. If you pick off some of the scales, you can also get bleeding, so there are eponymous signs that can help you with this. And especially if if the condition extends beyond the hairline, you must think about psoriasis. And in some patients, you can also get a crossover of both, and it's not unusual to have that. So coming on to something which you probably will see a lot in your clinics is very, very diffuse yellow scaling affecting our very young population, affecting the scalp, sometimes affecting the chest, sometimes affecting the folds. And this is cradle cap or seborrheic dermatitis. So this is a very common condition that tends to improve with age, but then you can get another peak, tends to be in young males, predominantly affecting the scalp, but can also affect other sites as well. We think that this is related to a yeast that is normally found on the skin surface, and the fatty acids, your body makes a reaction to the fatty acids that are produced by the yeast, and you get this inflammatory component. Very, very important. If it's not resolving, you must think about the bigger picture. As my colleague spoke about, history and examination, very important in dermatology. If it's persistent, you must think about immunosuppression. You will also see this condition in neurological disorders like Parkinson's disease and multiple sclerosis, although we're not quite sure about the etiology in these neurological conditions yet. And then if you look at the non-inflammatory cause, one of the most common conditions worldwide, this is pityriasis capitis or dandruff. So you can see there's two conditions of similar etiology, but you don't have that inflammatory component. And this is where you get bran-like flaking, and it can occur on the scalp again. And one condition not to miss, which can occur with persistent seborrheic dermatitis, is Langerhans cell histiocytosis, which is a clonal proliferation of antigen-presenting cells, which can sometimes, in 50% of cases, just affect the skin first. And you get purpuric areas that can affect the torso, it can affect in the napkin dermatitis region, and you can just get this persistent seborrheic dermatitis. And often, these patients will require a biopsy, and you will be able to pick up things with your bone profiles, your urine osmolality, and these patients need to be under an oncologist. So then you can get different patterns of scaling. So here you have almost these very thick scales that are going down your hair strands, and this is pityriasis amenacea. And this amenacea comes from the French word meaning asbestos. Hopefully none of us have seen asbestos or been exposed to asbestos, but this is what it looks like. And often it is not a specific diagnosis, it is a reaction pattern, and you have to look at the underlying cause. Is this inflammatory in nature? Is it infectious in nature, or is it idiopathic? And if we go back to inflammatory, it can be caused by eczema and psoriasis. If it's infection, can it be caused by a fungus? So that's the type of things that you need to think about. And often treating the underlying cause will resolve this. So for the last part of the talk, I wanted to focus on the different treatments. And I think it's really important to think about the different etiologies and how you think about your management. So if we start with simple things first of all, so you've got a zinc complex, a zinc pyrothone, very commonly found in over-the-counter shampoos, very helpful for pityriasis capitis or dandruff, and it will really help reduce the amount of scaling on the scalp. You've also got selenium sulfide-based shampoos, which will also help, and they also have anti-yeast activity and can be used for conditions like pityriasis versicolor. And then you have your Zol, so ketoconazole. These are also medicated shampoos that can help reduce the amount of yeast activity and can be used quite effectively to help with the scaling. Then if you're thinking about your inflammatory conditions, again, like your eczema and your psoriasis, you will have to use a steroid. But then also, if you're thinking about psoriasis, you will have to add in a vitamin D component to help reduce that cell turnover. If you're thinking about infections, then you have to think about antibiotics, especially if you're thinking about secondary impetonization, if you have a carry-on as well. And that's where antifungals come in as well. And sometimes, for example, in seborrheic dermatitis, if it's very severe, then you do need to think about oral antifungal agents as well. So that's hopefully a nice summary of scaly scalp conditions and treatment options. I'm more than happy to take any questions.
Thank you so much. That was absolutely brilliant. I'm sorry to derail you, but I think what we're going to do, we've got another scalp-based talk, so we're going to take all of the questions at the end and on both topics with both speakers for that after Sharon's talk. Now, just remember,